Good evening, everybody, and welcome to our Dräger webinar this evening on the COVID-19 ventilation challenges and experiences. So before we get started with the formalities, I would just like to go over the webinar functions. So on the right-hand side of your screen, you will see that there is a block with several little icons in it. Firstly, I would just like to do a sound and visual check. So if you could please use the little hand icon to raise your hand to indicate that you can hear me and see my screen. That is great. I do see the hands going up. So fantastic. Thank you very much. That means that you can hear me clearly and that you can see the screen. So we will have a question and answer session at the end of the webinar. So please use the question box on the right-hand side of your screen to type in your questions during the webinar. If I may also request that you just indicate who the question should be directed to, so either Prof. Grazeli or Prof. Omar, and then post your question so that I know during the question and answer session who you would prefer to answer your question. If you've just got a general question, then you no need to indicate who I should direct the question to. So all attendees will be muted for the duration of the webinar, and the webinar is being recorded, and the recordings will be sent out to all registered participants at soonest availability. With this said and done, I would like to offer a warm welcome to my colleague in Dubai, Margarita Singer, who is the Marketing Manager for Respiratory Care Region Middle East Africa, who will be introducing our first guest speaker. So thank you very much, Margarita, and I'm just going to hand over the presentation to you. If you could just confirm when you have received presentation ability.
Yes, so you should be able to see my screen now.
That is correct. Thank you very much.
Excellent. Thank you very much, everyone, and a warm welcome from my side as well. I am very honored to be part of this webinar today because I think we are bringing extremely knowledgeable and very experienced speakers to talk about the COVID-19 and the experiences in Italy and also in the South Africa. And just a disclaimer, the webinar presentation is for information purposes and has no commercial background. Dräger has neither influenced the content of the presentation nor taken any editorial measures. The sole responsibility for the content of the presentation and the webinar lies with the author, and all views expressed or information given are those of the author and are in no way attributable to Dräger. And Tanya have already mentioned, so the webinar is being recorded. Just a quick introduction to myself. My name is Margarita Singer, and I'm the responsible marketing manager for respiratory care at Dräger in the region Middle East and Africa. And today I am honored to introduce our esteemed guest speaker, Professor Giacomo Grasselli, who will be talking about the his experiences of the ventilation of COVID-19 patients. Professor Giacomo Grasselli is Associate Professor of Anesthesia and Intensive Care Medicine at the University of Milan. He is a Medical Director of the Intensive Care Unit of the Ospedale Maggiore Policlinico in Milan, in Italy, which is a tertiary referral center for the treatment of patients with acute respiratory failure and with extensive research experience in the field of mechanical ventilation, respiratory physiology, and extracorporeal respiratory support. He's one of the coordinators of the Italian ECMO network and now coordinating the regional network of COVID-19 ICU in Lombardy in Italy. During the last 3 years, Professor Grazelli was the Italian national representative in the Council of the European Society of Intensive Care Medicine, and he is currently chairing the intensive care section of the Italian Society of Anesthesia, Resuscitation, Intensive Care, and Pain Therapy. Professor Giacomo Grazelli is also a regularly invited speaker to international meetings. He actively collaborates with national and international research groups and serves as reviewer for several index journals. So a warm welcome from our side, and thank you very much, Professor Grazelli, for being our speaker today and for sharing your experiences of ventilating COVID-19 patients and also talking about the characteristics of the patient. So thank you very much. The stage is yours now.
So thanks, thank you, Margarita, and thanks to Dräger for inviting me. I'm a little bit sad because I was supposed to come to South Africa in person like 2 years ago, and then unfortunately we had this experience with COVID, so it was impossible for me to come to South Africa, and I hope that we will have the chance to meet in person very soon. So we're going to talk about problems and challenges of ventilating COVID-19 patients, and these are my disclosures. And the first part of this presentation, I will tell you very briefly what happened here in Lombardy, which is a region around Milan. As you know, Lombardy has about 10 million people. And for 10 million people, we had, before the pandemic, 750 ICU beds for the entire population. So it's about 3% of total hospital beds. And we had the experience of an ECMO network. We have, as you may know, quite a large ECMO network in Italy, 15 centers, 5 of them are in Lombardy. So we took advantage of that experience when we had to set up the COVID-19 ICU network, which I am coordinating now. And at the beginning, after the first days of the pandemic, we published this viewpoint in JAMA with Antonio Pesenti, my mentor, and Professor Cecconi. And as you can see, we had very different forecasts of the number of ICU beds according to an exponential or a linear increase of the epidemic. And luckily enough, thanks to the restrictive measures and to the strict lockdown that was implemented in the region first and then in the country, we basically could in some way control the growth of the epidemic according to a linear growth. But still, as you can see here, we had more than 1,200 patients in the ICU. And again, remember that we started from 750 ICU beds in total. So we established this ICU network, and this network has a central coordination, which I'm responsible for. And the central coordination is very important because it helps us to monitor real time the resources we have, namely the beds, and to allocate each patient to where there is an available ICU bed. And the goal is to optimize the patient allocation according to the patient characteristics, and also to collect demographic and clinical data for research purposes, as you will see. We also do regular meetings to share our clinical experience and to share management protocols in order to, in some way, homogenize the way we treat our patients, because as you know, we had to involve many ICUs in the region, and some of them were not experienced in the treatment of patients with severe respiratory failure. So this is what happened. We had until now we had 3 waves three pandemic waves. The first one, we had a peak of 1,500 occupied beds, and in the second and third one, we reached something like 1,900 beds. And this is the activity of our network. So we have treated in our ICUs more than 12,000 patients until now in the last 15 months. And as you can see, I would say with quite good outcome, because the mortality in the network is around 39%. And for example, for reference, recent German data are of about a mortality of about 51% in patients invasively ventilated. And as you will see, we due to the incredible, overwhelming number of patients, we had to admit to ICU basically only intubated patients. So we analyzed our data of the first pandemic wave, so of the first 4,000 patients, and we published these two papers. The first one is in JAMA, and the second one in JAMA Internal Medicine. And as you can see here, almost 90% of the patients were intubated at ICU admission, and another 5 to 6% were intubated during the ICU stay. And the patients had a severe respiratory failure, as demonstrated by a median PEEP value of 13 centimeters of water and median FiO2 of 70% at ICU admission. So these two papers were published with a limited data set. And as you can see from this paper, these highlighted factors were significantly associated with mortality, namely age, male gender, the need for invasive mechanical ventilation, the severity of hypoxemia at ICU admission, and among comorbidities, diabetes and COPD. As I told you, less than 10% of the patients were receiving non-invasive support at ICU admission, and half of them failed the non-invasive approach. And as you can see here, patients who failed non-invasive ventilation basically had the same outcome as patients intubated at admission, while patients who succeeded, who were treated only with non-invasive ventilation, had a much better survival. So this was very briefly our experience, and then I'm going to discuss with you the main challenges we are facing when treated patients with COVID-19. So I will discuss the role of non-invasive respiratory support, the pathophysiology of acute respiratory failure in COVID-19, the optimal setting of mechanical ventilation and the role of rescue therapies, and the impact of secondary infections. There are also other very important challenges and open points, like which is the best pharmacological therapy. We know that patients have long-term outcomes that can be very important. And there are also ethical issues, but I'm not going to discuss the latter 3 points. So let's see what we tried how we try to understand the role of non-invasive respiratory support. So what do we know about non-invasive management of acute hypoxemic respiratory failure? We know that the failure rate is quite high, as for example, was demonstrated in the lung safe study by Giacomo Bellani in a secondary analysis of the database. So not in COVID-19 patients, but in patients with, let's say, classical garden variety ARDS. We know that failure rate of non-invasive ventilation is higher in patients with who meet the criteria for ARDS, and in general in patients with low PF ratio or multiple organ failure. And what we know is that delayed intubation is associated with mortality, which leads us to the first important message. If we wanted to try non-invasive ventilation in patients with ARDS or acute hypoxemic respiratory failure, we always have to monitor very carefully the patient and not to delay escalation to invasive ventilation if the patient fails the non-invasive approach. Why non-invasive ventilation is appealing in COVID-19 patients? Well, because it is superior to standard oxygen, as demonstrated by these meta-analysis published in JAMA last year. And as you can see, non-invasive ventilation, and this is a general terms that encompasses both nasal high flow, non-invasive positive pressure ventilation, and CPAP, is superior to standard oxygen, both in terms of mortality and in terms of risk of intubation. Clearly, patients managed non-invasively have lower sedation needs, and very importantly, in pandemic times, when again you have a shortage of ICU beds, non-invasive ventilation, and in particular CPAP and nasal high flow, can be performed outside the ICU. And these are the guidelines, the Surviving Sepsis Campaign recommendations for the initial management of hypoxemia in COVID-19 patients. And as you can see, they suggest a trial of high flow, and if high flow is not available, of non-invasive positive pressure ventilation in patients with hypoxemia not responsive to conventional oxygen. In this guideline, CPAP and helmet CPAP is not reported, is not mentioned, but as you know, I'm from Italy, and for us, helmet is a very, very important interface. There are also risks connected to the non-invasive approach, especially in COVID-19 patients. The first one we already talked about is that if we delay intubation, if we do not recognize failure, patient will die more. So always strict monitor of the patient and try to recognize early signs of failure in order to escalate the support. The second risk is that when the patient is on non-invasive ventilation, we have less control of the ventilatory pattern and of the effort of the patient, and this increases the risk of patient self-inflicted lung injury. We will say something about that very shortly. And the third risk is the risk of environmental contamination and spread of the disease. So we know what self-inflicted lung injury is. Basically, in patients with high respiratory drive, what happens is that the patient develops high tidal volume, high transpulmonary pressure, and this leads to a vicious circle with lung edema, impaired gas exchange, increased drive, and development again of high transpulmonary pressure swings, which maintain lung edema and worsen lung injury. So in patients on non-invasive ventilation, it's very important to always keep in mind the risk of patient self-inflicted lung injury, even though, especially during nasal high flow or CPAP, it's very difficult, for example, to measure tidal volume. Regarding the risk of environmental contamination and spread of the disease, we have to remember that non-invasive ventilation is a droplet generating procedure, and droplets fall out within 1 meter from the patient. So the risk of exposure is high within a 1 meter radius from the patient. The risk of dispersion during high flow is, I would say, quite limited, and it's basically null during CPAP, especially during helmet CPAP. And so helmet CPAP can be a very important can be a very important interface because of if we want to minimize the risk of dispersion, also because we can apply antiviral filters at the outlet port of the helmet. However, it's been demonstrated that environmental contamination during high flow is not different from standard oxygen. So the message is that we can try non-invasive ventilation, and if we have and if we properly wear personal protective equipment, the risk of contamination and of nosocomial infections is quite limited. So we performed, together with Giacomo Bellani, a single-day prevalence study on the use of non-invasive support outside the ICU in 31 hospitals in Lombardy. On the day of the study, again, it was one single-day prevalence study. On that day, more than 900 patients were treated with non-invasive ventilation outside the ICU. And in our experience, non-invasive ventilation is mostly continuous positive airway pressure, mostly delivered through the helmet. And as you can see here, non-invasive ventilation failure the rate of failure was 37.6%. So very similar to what was reported, for example, in the Lung-Safe study. And as you can see, failure was defined as need for endotracheal intubation or patients who died without endotracheal intubation. And these were mostly patients with a do not intubate order. The factors connected with the risk of failure were mostly the severity of hypoxemia at the day of the study, as demonstrated by higher FiO2, higher PEEP level, and lower PF ratio, and markers of increased drive, respiratory drive and effort of the patient, which were lower PCO2, higher respiratory rate, and higher use of accessory muscles and higher dyspnea score. And this is very interesting. The rate of failure was very different in patients with a PF ratio below 150 or above 150. And it's interesting because the same threshold and almost the same curves were seen in the secondary analysis of the Lung-Safe study in patients with classical ARDS. The most recent study published on non-invasive approach in COVID-19 is this study by my friend Domenico Grieco, recently published in JAMA a few weeks ago. In this study, they compare helmet non-invasive ventilation, so helmet non-invasive positive pressure ventilation with nasal high flow. The primary outcome was the median number of days free of respiratory support, and there was no difference between helmet and IV and nasal high flow, while the rate of tracheal intubation was significantly lower in helmet and IV, but this was a secondary outcome. Again, to remind you and to underline the importance of monitoring the drive and the effort of the patient, I will show you this very interesting study published in the Blue Journal. This study is in patients with de novo respiratory failure, not COVID-19 patients, okay? And the study compares patients who fail or who succeed in non-invasive approach. And as you can see, patients who succeed in non-invasive approach are those in whom non-invasive ventilation is able to reduce swings in esophageal pressure and swings in transpulmonary pressure. So this study again tells us that it's very important to monitor the drive and the effort of the patient, and it's clearly not very easy to monitor to have an esophageal catheter in place, especially during non-invasive ventilation. But this study clearly shows that patients who succeed non-invasive ventilation are those who have a benefit from non-invasive ventilation in terms of reduction of effort and transpulmonary pressure swings. So there is a debate on the optimal timing of intubation in those patients, and especially Martin Tobin has published, I would say quite a intense debate with Luciano Gattinoni. Luciano Gattinoni was warning about the risk of self-inflicted lung injury and the risk of delayed intubation, while Martin Tobin in some way was cautioned about the risk of too early intubation in COVID-19 patients. So we do not have the answer yet. But I would say that, again, we need to monitor the patients. And whenever we have the feeling that the patient is going to distress, maybe we should in some way decide to intubate the patient. So it's not only the severity of hypoxemia, but also the respiratory mechanics compromise and the evidence of severe distress. This is the last slide regarding non-invasive management of COVID-19. During this pandemic, it's become very popular, the practice of putting the patients in prone position, even if they are not intubated. And so now everyone is doing a trial of prone positioning in awake patients. And it can be done also with the helmet, but clearly nasal high flow is very convenient as interface. Studies have demonstrated that this approach is feasible and that it is associated with improvement in oxygenation, which is comparable to what is observed in intubated patients, as we will see later on. We still don't know whether this approach is associated with improved outcome, especially because it's very difficult to put an awake patient with hypoxemia or severe hypoxemia in prone position awake for a prolonged period of time. So usually in these patients we do sessions of 2-3 hours prone alternated with session in the supine position. The second point I would like to discuss with you is pathophysiology of respiratory failure, which translates in a apparently very simple question, which is COVID-19 a classical ARDS? As you may know, Luciano Gattinoni, John Marini proposed a new definition of CARD, COVID-associated ARDS, and they claim that there are two phenotypes of COVID ARDS, and that the first phenotype, which is characterized by, as you can see here, mostly ground glass opacities, high compliance of the respiratory system, low elastance, and low intrapulmonary shunt fraction and low recruitability should not be considered as classical ARDS, while the second phenotype is much more similar to what we were used to think of as classical ARDS, because as you can see here, consolidations in the dependent lung zones. And they proposed that patients in the L phenotype should not be ventilated as we recommend for classical ARDS. So, for example, they should not be ventilated with low tidal volume, and in these patients, high PEEP level are not recommended despite the severity of hypoxemia. So this is a very interesting conceptual framework, and so we wanted to see whether this model of two phenotype is really encountered in the clinical practice. So first of all, is COVID the classical ARDS? Well, studies show that, for example, in COVID-19 patients, at post-mortem examination, you can see diffuse alveolar damage, which is, I want to remind you, the hallmark of ARDS, according to the histopathological hallmark of ARDS, according to the Berlin Definition Task Force. And we know that patients with COVID-19 meet all the criteria, the diagnostic criteria for COVID-19. So from a, I would say, semantic point of view, from a definition point of view, COVID-19 is ARDS because it meets the criteria of the Berlin definition. So the difference is that ARDS is a syndrome, as explained very well by Jean-Louis Vincent in this editorial. ARDS is a syndrome. Vincent says that a diagnosis of ARDS is actually not a diagnosis, because syndromes are not diseases, and ARDS can be secondary to a number of diseases which are very, very different from each other. For example, we know that we can have ARDS secondary to pneumonia, secondary to abdominal perforation, or secondary to pancreatitis or trauma. And clearly pneumonia is very different from trauma, and treatment of pneumonia and trauma is completely different. So ARDS is a syndrome, while COVID-19 is a distinct disease. And this is mostly the difference. But from a definition point of view, ARDS meets the criteria of the Berlin definition. COVID-19, sorry, meets the criteria of the Berlin definition of ARDS. Then we tried to study a little bit more in details the pathophysiology and the clinical characteristics of those patients in this paper that was published in the Lancet Respiratory Medicine a few months ago. Together with Marco Ranieri, we analyzed 300 patients with COVID-19. All those patients were treated with protective mechanical ventilation. As you can see here, median PEEP level of 13 centimeters of water, median PF pressure of 124 millimeters of mercury, and median FiO2 at ICU admission of 60%. In all those patients, we measured the static respiratory system compliance, ventilatory ratio, which is a proxy of dead space, and D-dimers, which are a proxy of the severity of the involvement of the microcirculation and of the coagulation impairment in those patients. In a subset of these patients, we obtained the CT scan, and we compared these patients with a control group of patients with classical ARDS of different etiologies. The control group was obtained from the Berlin definition and the lung safe databases. So it's, I think, a very interesting study. As you can see here, patients with COVID-19 ARDS were more frequently male and had a median body mass index, a higher median body mass index compared to classical ARDS. And in general, they had a more severe ARDS. Regarding the static compliance of the respiratory system, patients with COVID-19 had a higher static compliance compared to patients with classical ARDS, but a huge inter-individual variability of compliance and a huge dispersion of the compliance values. So it's true that the median value was slightly higher, 41 ml per centimeter of water, compared to 32 ml per centimeter of water, but a huge dispersion of compliance values as observed also in classical ARDS. No difference in total lung weight. COVID-19 patients tended to have high D-dimers, indicating, as we know, the tendency to thrombosis, activation of coagulation in those patients, and interestingly, the value of the dimers were correlated with a ventilatory ratio, and this was not unexpected. We know that if we have thrombosis of the vascular bed, the dead space fraction is expected to be higher. You can see here the distribution of compliance values in COVID-19 and in classical ARDS. So it's true that the median value of compliance in COVID-19 is slightly higher, but as you can see, unimodal distribution of compliance, so no evidence of the two phenotypes. And again, only 5% of the patients with COVID-19 had compliance values higher than the 95th percentile of classical ARDS. And other studies in the literature, as we will say later, also show huge variability of compliance values. So not clear evidence of the fact that COVID-19 is characterized by higher compliance compared to classical ARDS. This is very interesting. We subdivided the patients according to the D-dimers and the compliance values. So we had patients with lower D-dimers and lower compliance compared to the median values. And so we had 4 groups. And as you can see here, patients with low compliance had a lot of non-ventilated regions, those black regions. And patients with high D-dimers had a lot of hypoperfused or not perfused regions, these purple areas. And this is a three-dimensional reconstruction of the pulmonary vascular tree. And as you can see, the red dots are thrombotic lesions. So most patients with high D-dimers have extensive thrombosis in the pulmonary arterial tree. And interestingly enough, patients with low compliance and high D-dimers, so patients with both epithelial, alveolar, and vascular damage had a significantly higher mortality, 56%, compared to the other groups. So we propose that patients with both impairment of compliance and high D-dimers have significantly higher mortality compared to the other patients. Other studies have assessed the respiratory mechanics in COVID-19. This is a study published by Odbu in the Blue Journal. It confirms that patients with COVID respiratory mechanics is highly heterogeneous and not really different from non-COVID ARDS. And again, also in this study, no distinct phenotypes were identified. These other studies by Domenico Grieco, they matched 30 patients with COVID-19 with 30 patients with ARDS from other etiologies, and they confirm that respiratory mechanism is heterogeneous, that compliance is slightly higher in COVID-19, but not very different from classical ARDS. The potential for lung recruitment is variable, and the response to PEEP was in COVID-19 patients in some way dissociated with the recruitability of the patients. We performed together with Tommaso Mauri this study in our ICU in a very limited number of patients, but we used electrical impedance tomography to study the potential for lung recruitment and ventilation to perfusion matching. So we performed a two-step PEEP trial from 5 to 15 centimeters of water in random order, and we were able to study not only the ventilation distribution with EIT, but also the perfusion distribution, and we confirmed using EIT that there was a high inter-individual variability, in the potential for lung recruitment. And we also showed that COVID-19 was characterized by a significant mismatch between ventilation and perfusion, and with the prevalence of non-perfused lung units, so of dead space, to non-ventilated lung units, so to shunt. So this study nicely shows with EIT that the main mechanism is VQ mismatch, and with significantly high dead space fraction in COVID-19. Also in classical ARDS, this is a secondary analysis of the lung safe study in more than 1,000 patients with different etiologies of ARDS. You can see here that also in classical ARDS, a good proportion of the patients have compliant values higher than 40 ml per centimeter of water. So in some way, the idea that classical ARDS is characterized by low compliance is in some way misleading. And also what we think about the relationship between compliance and PF ratio is not really confirmed by the data. This is a table which is published in the electronic supplementary material of our paper in Lancet. According to this value that reports only median values of compliance and PF ratio, you can see that apparently in classical ARDS there is a clear relationship between oxygenation impairment and compliance, while this relationship is lost in COVID-19. But again, this is only median values, and when you look at median values, you lose the granularity of the data, because then if you analyze other data sets, for example, in the study by Domenico Greco, you see that in COVID-19, apparently there is the same relationship between compliance and oxygenation impairment. And in classical ARDS, if you look at the study by Pambar published in the Blue Journal, the relationship between compliance impairment and oxygenation impairment is very loose. So also from this point of view, we can say that COVID-19 is very similar to classical ARDS, and this has been summarized very nicely in this viewpoint, in this editorial in Lancet Respiratory Medicine, that says that the idea of two phenotypes is very interesting, is very appealing from a conceptual point of view, but it's not really confirmed by the data coming from the studies, and it could be overinterpreted or inappropriately applied in the intensive care unit, because COVID-19 associated ARDS is in the end ARDS, and the reports of the two phenotypes come from studies in a very observations in a very limited number of patients. The letter in the Blue Journals that for the first time reported the idea of the two phenotypes came from data from 16 patients, and these experts strongly recommend the adherence to evidence-based management. So the idea is that COVID-19 ARDS is ARDS and should be managed as classical ARDS. So how do we set mechanical ventilation in these patients? We recently published this scoping review in Critical Care Journal. This is a network geometry diagram, and the size of the circle is proportional to the number of studies that reported that parameter. So we analyzed 26 studies that reported at least one respiratory parameter within 24 hours from ICU admission in more than 14,000 patients. And as you can see here, this table summarizes mechanical ventilation settings. And for reference, we also reported the same data from the LungSafe database. And as you can see, protective ventilation settings are largely applied in COVID-19 patients. If you look at tidal volume, most studies report tidal volume within the protective range of 6-7 ml per kilo of ideal body weight, and plateau pressure and driving pressure within the protective range. A relatively higher PEEP level is applied compared to what is reported in the LungSafe study. And also, this report confirms that compliance values are highly variable also within the studies. As you can see here, we go from 27 to 41 ml per centimeter of water, which are values not really different from what is reported in classical ARDS. In patients invasively ventilated, we have a lot of problems in COVID-19, several problems related to sedation, to the understanding when is the optimal timing for switching to assisted spontaneous breathing. We know that COVID-19 patients are very frequently difficult to wean, and we still don't know which is the optimal timing on tracheostomy. And these are all open points, and these are all clinical challenges that we encounter in our clinical practice. And if you want, we can discuss that in the Q&A session. We also analyzed the use of rescue therapies, the frequency of use of the most important rescue therapies. And it's clear that in COVID-19 patients, compared to what is done in classical ARDS, neuromuscular blocking agents, prone positioning, and nitric oxide are used much more frequently. And it's very interesting to see how frequently neuromuscular blocking agents and prone positioning are applied in these large case series, especially from Europe. We performed a retrospective observational multi-center study on the use of prone positioning in intubated patients. So we analyzed 1,057 patients of the first pandemic wave in Italy. As expected, most of them had moderate to severe ARDS. As you can see, prone positioning was applied in 61% of the patients, which is a lot, especially if you think of the workload that we have in the ICU. And as expected, patients who were put in prone position had more severe disease, and for this reason had higher mortality and duration of mechanical ventilation. We did not perform any analysis to assess the efficacy of prone positioning. We only want to describe the use of prone position. We also performed a sub-study in 78 patients in whom we had the response to prone position in terms of oxygenation and respiratory mechanics. And what we observed is that almost 80% of the patients were oxygen responder, meaning that they had a significant improvement in PF ratio with prone positioning, in PaO2, actually not in PF ratio. And non-responders had more severe disease and higher ICU mortality, but again, this is only in 78 patients out of 1,000, while interestingly enough, prone positioning did not affect respiratory mechanics in terms of both compliance and ventilatory ratio. A very important rescue treatment is ECMO. The preliminary reports reported a very low frequency of use of ECMO, which is understandable due to the overwhelming number of patients that we had to assist in our ICUs. But since these patients are characterized by ARDS and by severe hypoxemia, in many patients, which is in many patients refractory to conventional management, the use of ECMO has progressively increased, as demonstrated by this report from the EuroELSO network that shows a survival rate of 55%, and also in this report from the ELSO registry that shows a mortality rate which is completely comparable, completely similar to what was reported in the EOLIA study published in the New England Journal of Medicine in ARDS. A final consideration on the setting of mechanical ventilation: we are in the era of personalized and individualized medicine. So it's very good to give, let's say, general indication and guidelines, general recommendations, but then it's very important to study the pathophysiology of the single patients and to adjust the setting of mechanical ventilation to the pathophysiology of that patient. We know from the work of Caroline Calfee that two phenotypes can be identified in ARDS, and this phenotype has been identified according to a number of biomarkers and inflammatory mediators and some clinical parameters. And so Caroline Calfee has been able to identify two phenotypes in ARDS, one which is a hypoinflammatory phenotype and the other one is a hyperinflammatory phenotype, and these two phenotypes have different outcome and also different response to PEEP and to fluid restriction. So this study is very important because it gives us the proof of concept that ARDS again is a garden variety of different entities, and then it's very important to identify phenotypes in order to understand which is the optimal treatment for that single patient. And these two phenotypes have been identified also in COVID-19, always by Caroline Calfee. You can see here they compared the COVID-19, 39 patients with COVID-19 with patients from a large study in ARDS, and they also matched the 39 patients with 39 similar patients from that study. And interestingly enough, they showed that COVID-19, the prevalence of the hypoinflammatory phenotype was higher compared to classical ARDS. So again, this indicates that the idea that COVID-19 is characterized by hyperinflammation and cytokine storm, again, is not really supported by the real life data. And also in the accepting and encouraging the idea of personalizing the setting of mechanical ventilation, I want to tell you that again, EIT can be very useful. This is a very interesting research letter published in the New England Journal by the group of Diederik Gommers. They performed a decremental PEEP trial, and they used EIT to set the optimal level of PEEP in COVID-19, and the optimal level of PEEP was was the level of PEEP that was associated with minimal recruitment and minimal hyperinflation. And as you can see here in these nice images, the yellow, the orange areas are areas of hyperinflation which are prevalent at higher level of PEEP, and these white gray areas are areas of consolidation, the recruitment, which are clearly more prevalent at the lower level of PEEP. The final problem is the problem of secondary infection. As we know, patients with COVID-19 are at high risk of hospital-acquired infections due to a number of factors, including the SARS-CoV-2 infection per se. We performed this retrospective study that has just been published in CHEST on 800 adult patients with severe COVID-19, and the study was aimed at assessing the incidence, microbial etiology, and the impact on outcome of secondary infections. we demonstrated that almost half of the patients developed at least one infectious complication, and factors associated with the risk of infection were age, PEEP, and the use of broad-spectrum antibiotics at ICU admission. The most common infection was ventilator-associated pneumonia, and most ventilator-associated pneumonia, the majority of VIP, were due to gram-negative germs. And in our reality, in these 8 ICUs in Italy, hospital-acquired infections were due to multi-drug-resistant bacteria in almost 40% of the cases. And as you can see here, patients who developed an infection did not have increased mortality, but this is understandable because death and infection are competing events. So patients who die, basically they do not develop an infection, but patients who had at least an infectious complication had a significantly higher duration of mechanical ventilation, of ICU length of stay, and of hospital length of stay. And this is my final slide. I want to invite you to follow this project that we started together with Cochrane France and Sorbonne University. It's a living network meta-analysis. It's called the COVID-NMA project. And if you go on the website, you will be able to find a real up-to-date review of all the trials, of all the pharmacological trials on COVID-19 patients. The review is, again, it's a living review, which is updated weekly, and you can also, if you want, you can also build your own comparisons, again, different treatments. So I'm not going to, I didn't discuss in this presentation the pharmacological treatment of COVID-19, but if you are interested in that, you can really find all the updated information in this website. So thank you very much with your attention, and I'll be happy to take your question at the end of the session. Thank you.
Thank you very much, Prof. Grazelli, for that very informative lecture. So I would just like to hand over now to my colleague here in South Africa, Nadia Ferber, who is the Marketing Manager for Respiratory Care in South Africa. Nadia Ferber will be now introducing our second speaker, Prof. Omar from South Africa. So Nadia, I'm busy handing over to you. If you will just confirm when you have the ability to present.
Thank you, Tanya.
Perfect, thank you. I will mute myself.
Thank you. Good evening, everybody. It is my pleasure to introduce our second speaker tonight to you, Prof. Shahid Omar. He's our critical care specialist at the Chris Hani Baragwana Academic Hospital, which we call short BARA, here in South Africa. He's in the intensive care unit. His interests includes fluid therapy, extracorporeal therapies, and point of care technologies in the critical ill patients. He's an associate professor at the School of the Clinical Medicine at the University of Witwatersrand. And Prof. Omar is also a council member of the Critical Care Society of South Africa and heads up the Southern Gauteng branch. Prof. Omar, thank you very much for joining us tonight, and I'm handing over to you. Thank you.
Thanks, Nadia, and thank you to Dräger for making this event possible, sponsoring it, and thank you for Giacomo Grosselli for giving us a real-world expert talk on COVID and ventilating these patients and the ideas around it. I'm going to be sharing some of the local data. It's just a small bit of data from the second wave across a few weeks that covered the peak of the pandemic, and it's just a small bit of data from a small ICU. We've got 18 ICU beds for COVID, and we had 59 admissions during that peak few weeks, about 8 weeks between December and January, or end of December and January. So there we have it. Our ward converted into an ICU, and we started initially, so we had a bit of change in tech. We started initially supporting internal medicine and tried to run 60 beds with 2 nursing staff, and it was just an impossible mission through the first wave to try and give ICU care to these patients. So for the second wave, from September onwards, we had a change in tech, and we actually took some of the staff from our main ICU and tried to decrease the number of ICU beds. So essentially we tried to get up to 36 beds or down to 36 beds, but we effectively could only get about 18 beds, probably 20 at the most, with the staffing that we had. And I'm going to share the data from the second wave there. And then we also had some support from some of the NGOs who helped us create our own COVID PCR lab just to facilitate service in both the COVID and non-COVID ICU, and that was quite successful and was converted into a lab in the second just before the second wave. So obviously the chaos of the second wave was some weeks towards the middle of December to the end of January, and we had 59 patients admitted to our COVID ICU. And as you know, that we had the B1351 lineage, which was typically known as the South African variant, although we're not meant to say that now. So I just want to go through the treatment we had. So during the second wave, about a third of our patients actually got received about a third received steroid pulse therapy in addition to the normal steroid therapy. Also, just about a third or a little more than that received other immunomodulatory therapy, mainly immunoglobulin, or what we call polygam, and a little bit of tocilizumab as well. So some of these patients, so around 35–36% received either one of these. I want to just mention this study because I'm going to refer to it, and this is a really great achievement by the president of our Critical Care Society, Prof. Dean Gopalan, the ACOS study, and Bruce Bickard, who actually got 10 countries in Africa to actually generate some really local or continental work and highlighting the shortcomings that we have, and so we can actually try and overcome them. Unfortunately, although we were contributed towards the resource component of this study, we didn't get our ethics, which by December 2020, and we were not able to actually include patients because the study was going to close in a few days. So we contributed to resource availability, but unfortunately, from a patient point of view, we didn't. But you can see the issues around nearly half the patients not getting into ICU where an ICU bed was requested. So it's really a big problem in Africa. So I'm just going to look at our patient group. You can see that very similar to the ACOS, we've got about 55% males. I think the ACOS had 60% male. The age group in our cohort was around 47, so much younger than internationally, which is usually around 60. And in fact, even the ACOS study was around 56. We had quite strict criteria. I think we may have overreacted from the first wave, where we went through the 3 components of our guideline to admit. But we did admit elderly patients if their frailty scores were good. And you can see the organ function score very similar. A SOFA score of 4, a median SOFA score of 4, very similar to the ACOS study and other data from around the world. From a comorbidity point of view, actually exactly the same as everywhere else. Hypertension, diabetes, almost 40% of our patients had a BMI over 30. And you can see that the HIV group, very similar to the ACOS study, we had 8.5% and they had 7.7%. Here are some differences though. You can see that just under 60% or 56% of our admitted to ICU, at the COVID ICU, were ventilated. And if you look, it doesn't look too different from the 40% that required invasive mechanical ventilation in the ACOS study, but the real difference lies in this group over here. This 44% that came into the ICU had access to either high flow oxygen, high flow nasal cannula oxygen, or to non-invasive ventilation, or both at at different time points. But this group all had one of those therapies, and we've heard from Prof. Grasselli, this is a group where you actually can have 60% of patients being quite well, or even more, 65%. And in fact, that was pretty much our experience. And you can see that in the ACOS group, 46% actually didn't have access to ventilatory support. So this is probably the big difference, and you'll see that difference come out. Now, when you look at admission variables, you can see the oxygen requirements are really high, 75% oxygen concentration required, with significant hypoxemia. There's low PCO2, 68 millimeters mercury. And once again, highlighting that compliance issue that Prof. Grasselli mentioned earlier, a relatively normal looking CO2, although the ROX index was low, suggesting a high work of breathing. And then again, this PF ratio of 96. And you can see that the AA gradient is quite high. Now, if you look at our median PEEP, was not very high, around 10, or you might say it's high compared to non-ARDS patients or non-lung pathology patients. And our peak airway pressure, or if you want to extrapolate the driving pressure, because we used predominantly a pressure mode, although we used several modes, driving pressure of around 12 centimeters of water. Now, I want to talk about this really a great scoping review by Prof. Grasselli's group. They actually looked at a large cohort, 14,000 patients in 26 studies, 25 of these studies from Europe and North America. And certainly, we got a lot of advantage from the lessons they learned early on in the pandemic. By the time we hit the pandemic, we had already learned that non-invasive was the way to go, and certainly there was a big plus for us. But I want to show you some of the data, and you can see that the plateau pressures, because 4 of the studies reporting a preference of mode of mechanical ventilation, 4 out of 5 use volume control and only 1 pressure control. But you can see that the plateau pressures around 23, very similar to our peaks of around 22, and then the PEEP levels also you can see between 10 and 13, and compared to our 10. So not too dissimilar from our data. What is remarkable is I want to show you this PF ratio, and now we've heard that in fact if you look at this paper here from about 5 years ago, the lung safe study, the compliance in ARDS is quite varied, from the early 20s to around 50, and in fact that's pretty much what's shown in the COVID data. But what is interesting is really the PF ratios. The median PF ratios here you can see 161, and we have values under 100. So we've got a much greater proportion. And if you remember, Prof. Grasselli mentioned the 150 threshold, where we start having big mortality differences. You can see we are on either side of the 150. So not surprising that we have a higher mortality, or potentially a higher mortality if we do find that. And again, from the scoping review, the PF ratio range from 100 to 198, but a significant proportion low down here. If we look at the inflammatory burden and the other markers, we can see that a high CRP and a high D dimer, reflecting probably the issue around endothelial injury and microvascular thrombosis and other contributors to the hypoxemia. and then a CRP reflecting the inflammatory component. And you'll note that other organ dysfunction, or at least acute kidney injury, doesn't seem to play a role early on in the disease, at least in the second wave. The third wave may actually be a little different. I'm going to look at just the baseline blood gas values, and again, we looked at the PCO2, the PO2s. There was hypoxemia, and the lactates are really high. Whether this reflects hypoxia from the hypoxemia, or probably more likely a high sympathetic or an increase in sympathetic tone or sympathetic overload from the severe hypoxemia at this early stage, at least. I'm going to look at vasopressor support. So we had about a 20% vasopressor utilization at baseline, and you can see that that's not too different from the ACOS study, around 20% or 19%. However, if you look at the mortality related to this vasopressor utilization, we had 8 out of the 12 patients initially on admission having vasopressors, and 2/3 of them died. And then in the next 72 hours, we had an additional 5 cases requiring vasopressors, and all of these died. And so you can see that vasopressor utilization is really significantly associated with mortality, and almost over 3/4 of patients actually died. When we look at renal replacement therapy, we had just under 15% utilization. And in fact, if you look at the ACOS study, it was under 10%. So we might have had a little more access to renal replacement therapy, or we might have been part of the lucky group in terms of access to resources. But again, utilization of RRT, or at least requirements for it, were associated with a very high mortality. You can see 6 out of the 7 patients died. Now, just going to nosocomial pathogens, and I'm just going to touch on this here. Once again, half of the patients, or close to half of the patients, had a positive blood culture, and we use that as a surrogate for nosocomial infection, obviously, because I'm not giving you individual detailed information. But what is interesting here is also the type of pathogens, and very similar to what the previous speaker has talked about, is that we've probably got gram-negatives as a big problem. But in fact, if you look at the gram-positives, okay, they seem to be a reasonably high proportion that we normally see, and then some fungal infections also. So certainly, what we think is a bit more gram-positive and more fungal infections or Candida infections than what we accustomed to. From a bleeding perspective, and I think this is important, probably because part of our treatment strategy is actually to treat the underlying microangiopathy that we suspect is there, and we anticoagulate those patients with high D dimers. And you can see that significant bleeding is therefore something to watch out for. But once again, just to show that if you are monitoring factor Xa levels, then the bleeding risk is reasonably low. We had 2 patients had significant bleeding. One required 1 unit of PEC cells and the other 2 units. So that's something that's achievable, safely at least. Now let's look at some of the outcomes. The length of mechanical ventilation. This was actually, surprised us somewhat, this median time of 4 days. And really, I thought perhaps we had a lot of non-COVID pneumonia patients in the non-COVID ICU, maybe for trauma and other reasons. But if you remember correctly, from December, we had the alcohol ban. And in fact, we had an empty trauma unit. So it was unlikely. And we looked at it, and a very small proportion of patients were actually non-COVID pneumonias. So we actually looked at the distribution of mortality in these ventilated patients. And we found that, in fact, a large proportion that were ventilated for or under 3 days had actually died. And in the middle group, between 3 and 7 days, that's where we actually had our survivors. That group had about a 30% chance of survival. And then once we went beyond 7 days, then just over 80% of patients died. So that may explain this duration. Just another way to look at that data. Now I'm going to just look at ICU mortality, and this part I must say, as I previously said, I was almost afraid to look at it because in those few weeks of pandemonium and chaos, one wondered if we were saving anybody's lives. And actually, when we looked at the data, we were quite relieved to say that, in fact, 47% of people in ICU or admitted to the ICU died. Now, when we take a closer look, you'll see that of the group that were actually invasively ventilated, that was actually higher, 55% then died. And then of those of that group that were non-ventilated, but these had all received either high flow oxygen or non-invasive ventilation at some point during their stay. You can see that the mortality was only 38%. Now, that's not too dissimilar from this big set of data from last year. Once again, Grasselli's group, 1,700 patients, and this is 48.7%. And this group, this had a small outstanding group still in the ICU, and that number may have differed somewhat, but really reflecting a very similar experience with a large number, with a much larger number of patients. But now, if you look at the ACOS study, you can see that with the lack of resources, the mortality in those requiring mechanical ventilation was almost 80%, and that actually just shows you the lack of resources that we have. In fact, if you think that in Africa, it's not, you won't have, there wasn't a SATS monitor or a SATS probe for each patient that was ventilated, and that speaks to our resource problems in terms of equipment. I don't even want to mention the human resource issues that we have. Now I'm going to look at ICU mortality from a different perspective that's been described by the previous speaker, and you can see that that's the PF ratio. And you can see that this magic number of 150, again, 60% of our patients had this PF ratio below 150, and so that's not surprising that in fact the bulk of the problem is in fact a severe hypoxemia. And if you think that 60% were prone in some studies, that's not surprising because if you think of the indications of proning by the PROCEIVA study, it was actually a PF ratio below 150 for the PEEP of more than 5 and an FiO2 of above 60, which I can tell you virtually all of these patients would have met. And therefore, all of these patients deserve an attempt at proning to improve oxygenation and ventilation, or at least to attempt to improve them. And you can see that once again, 60% of this group actually died approximately, and 40% of the group had a PF ratio greater than 50, and about 40% of those died. So to look at it in a different way, 3/4 of all our deaths were in this group of PF ratio less than 150. There was only a quarter in this group here. And this is a nice study by Patel et al. I'm going to go through a little more detail, but I want to show you pretty much a mortality of 42% overall and an increasing mortality as our PF ratios decrease from 300 to 200 to 100. Now I'm going to look at some admission data regarding our patients, and you can see that I've tried to separate the survivors and non-survivors, and probably the ones that stand out are the FiO2 and FiO2 of 1 in the non-survivors. You can see that the PaO2 is probably lower but didn't reach statistical significance. The PCO2 was not predictive at this point. The respiratory rate not. The PF ratio, you could probably make a case that yes, if we had bigger numbers, it would be different, and that reflects that high FiO2. And again, that gradient, even though it doesn't reach the statistical significance, you won't argue that a gradient of 400 is different than 250 or 260. And then this is an interesting one: the peak pressures on admission into ICU. significantly higher in the non-survivor group. And then the organ function, you can see that significantly higher organ dysfunction, the SOFA scores. And then this one surprised us, and I'm just putting it out there because I'm not sure what to make of it, the higher HP in the non-survivors, or if it was just coincidental. So to look then what happened at 72 hours. So at 72 hours, we still have this issue around an FiO2 still being predictive. Okay, but now what becomes interesting is that PCO2 becomes predictive for non-survival. And you can see that, I haven't got tidal volumes here, unfortunately, but you can see that our peak pressures were not different. And I can tell you now, I haven't put it up here, but our peeps were no different. So our driving pressures were really no different, and our rates not different. So this PCO2 reflects a deterioration in compliance from the beginning. So certainly this group has deteriorated from a compliance point of view, and certainly this is now predictive of a poorer outcome. Now what is also significant is that the inflammatory response becomes important here, and it's now statistically different and obviously clinically different, and the SOFA score as we expect. Now, I really want to try and tie that data up with this really great paper here, published not too long ago, looking at the natural history, trajectory, and management of mechanically ventilated COVID-19 patients. And you can see this was a multi-center trial, observational, and they found 600 mechanically ventilated patients in the UK. What they did was they used logistic regression, but they also used machine learning and artificial intelligence to try and characterize the clinical evolution. And this was data from the first wave. They used Berlin criteria, as we've looked at for oxygenation, 300, 200, 100, which we're all accustomed to. And then the outcomes, they looked at survival, they looked at resolver versus non-resolver in terms of oxygenation. And then they looked at a prone responder versus non-responder, that is the ability to maintain a PF ratio over average of over 150 over the 7 days after the first proning. And it's no surprise what they found. We expect this, and we know that PF ratios, the mild disease has a much better survival than severe disease and oxygenation deficits, and we know that. But this is interesting, with an overall mortality of around 43%, which is now what the number we're getting to see around the world, probably around 45, 40 to 50%. If you look at the oxygenation progression in the first 7 days, a third are going to deteriorate. So in other words, you've got a small window to try and optimize these patients and to say, hey, I've done everything I can for these patients. And then a large proportion are going to be flat. They're just going to do nothing. And that's the one that, you feel helpless, you've done everything you can, and there's just no movement. And then much smaller proportion then will deteriorate, are going to improve. So 25% will improve somewhat. Now, on the y-axis here, this is a really interesting curve. On the y-axis here, they've put in the AI values for predictive values for each of these parameters. So which one would predict survival or non-survival? And the higher the value, the higher the predictive advantage. And you can see that on the x-axis, they've got time. So in other words, if I can tell you that this particular parameter has a great predictive ability at admission, but then obviously by 72 hours, it's not predictive anymore, or it's much less predictive. And in fact, the value, for example, one of these parameters over here might be a very low predictive value here, but as you go along in time, it actually improves. And then some will actually decrease and stay down, and some will decrease and eventually go up, etc. Now, this is quite important, because if you look, the PF ratio, or oxygen requirements, or oxygenation, is a very quasi-linear, and it's always going to be telling us, and it actually improves over time. So it's really a useful tool oxygenation. And here I've put, here it's the PF ratio. I'm going to extrapolate our FiO2 requirements because we don't have big enough data to show a significant PF ratio. The next one I want to show you is this green one over here, the ventilatory ratio. So the ventilatory ratio has been previously mentioned as well. It's basically the minute ventilation times the PCO2 as a proportion of that predicted by a normal PCO2 and 100 mils per kilo ideal body weight. And obviously, this is directly proportional to PCO2, and therefore the higher the PCO2, the higher the ventilatory ratio. And I'm going to extrapolate or use our PCO2 data as a surrogate for this. And then the CRP, you can see that the CRP actually starts off not very predictive, and its predictive ability actually peaks around the 72-hour mark. And then finally, if you look at peak pressure is really useful to take note of in the beginning. And then by day 2 or 3, it's actually not as predictive, in fact, as it was there. So why is all of this important? And the reason I'm saying this is because I've looked at our 72-hour data, and I've just showed you, gone through that, and you can see that PF ratio or oxygen, some mark of oxygenation, whether it's oxygen requirement or some mark of oxygenation, is probably going to be useful going forward in time. A mark of ventilation or ventilatory ratio like CO2 might be useful for predicting things, and then the CRP as well. Whereas the peak pressure is only going to be important here. And so what this really tells us is that we've actually, once we've already got to this point, and for example, if our ventilatory ratio is bad or predictive of a poor outcome, or if our PF ratio is predictive of a poor outcome, we've actually lost the ability now to do something. So in actual fact, what we want to do is we want to act in this first 24-hour period, not later than 48 hours, to see if we can mitigate the situation that may arise here, so that we know when we get here, if we've got a predictor of poor outcome in terms of either PF ratio or ventilatory ratio or inflammatory burden, we know we've already done something about it, or everything we could have done about it, because at this point, then the prediction turns to reality, or so to speak. So we've got a small window, and there are not too many interventions that we can do, but we need to then carry these out early. The next one is D-dimer, and that's probably related to inflammation and to the microangiopathy. And again, you can see that the D-dimer non-survival is much higher, and we do everything we can in terms of anticoagulation. But I want to show you some data, and I want to just thank Alex van Benstein. You all, those that work with you probably know her from pulmonology at Barra, and she's doing this PhD. And one of the bits of work that she's doing around this is looking at the TEG evolution. And this is a different group of patients, so not all in ICU. So there are some differences, but essentially this is an admission, this is 48 hours later, and then this is day 10 or resolution, and these are the TEG values. And what she's found is that in this group of hypercoagulable people compared to the non-hypercoagulable people, what's clear is that there's a problem with fibrinolysis. But in addition, despite anticoagulation, and you can see these anti-10A levels in this group. Obviously, they were not. These were not. The indication here was only for prophylactic anticoagulation, but they were well great. So just to say that at resolution or day 10, there seems to be some contribution of platelet effect to the clot strength that still persists despite full anticoagulation. And so this may be something else from a pathophysiological point of view to look at. And she's going to do some work. She's doing some work on autopsy studies and megakaryocytes in lung tissue. So I want to just end with this quick summary. So we acknowledge that the pathophysiological mechanisms and their possible contributions are not fully elucidated, and that's quite clear from the previous speaker and some of the work that he's done and shared with in terms of.
Sorry, everybody. It does seem that we have lost audio and visuals with Prof. Omar. We will try and get him back on the line as soon as possible. Please do not go away, and the webinar has not ended yet. So if you'll just give us another second or two to try and get.
What happens is that
Prof.
as we reach the peak of the pressure over here, this image here is this image over here is a subtraction of this image minus the reference image. So you can see that here we've actually got loss of ventilation in orange, and loss of ventilation in orange in a dependent area, in a non-dependent area, is highly suggestive of overdistension. So what we do is we go back down this step and we find this overdistension disappearing, and here we actually then at this particular pressure we find now we've actually got improvement of ventilation compared to our reference point here, and there are some marginal differences. What this has told us that this particular patient, higher pressures were not going to help us, and so now the last step here is obviously to prone this patient and obviously see if we can't reduce our mechanical burden on these lungs. Okay, with that, I want to thank you and thank the team at Bera for all their hard work, and thank you to Dräger and Prof. Grasselli for his talk. Thank you very much.
Thank you very much, Prof. Omar, for the very informative presentation. So I would like to open up the question and answer session right now. So if you have any questions which you would like to ask either of our guest speakers this evening, please do type your questions into the question box, which can be found on the right-hand side of your screen. So there are two questions that I did see coming through, and I think these are for anybody to answer. So how do you reliably calculate your driving pressure in a pressure-controlled mode?
If I can, well, it's very simple. You exactly as you do it in volume control ventilation. It's the only thing is that it's important to perform an end inspiratory occlusion maneuver and an end expiratory occlusion maneuver. And the driving pressure is the difference between plateau pressure and total PEEP. So the end expiratory occlusion is important because if you have intrinsic PEEP, you need to calculate total PEEP. And the inspiratory occlusion is important also in pressure control mode, because there is the false belief that the level of pressure control is equal to the plateau pressure, but this is not, especially in patients with, for example, high resistance of the airway. If you do an occlusion, you will still see a difference between the peak pressure and the plateau pressure. So in pressure control mode, it's exactly as in volume control with end inspiratory and end expiratory occlusion. We can't hear you, or at least
Thank
I can.
you. Sorry. Thank you very much, Prof. Grasselli. I do feel that that answers the question quite adequately. So the second question is, at which point would you escalate to ECMO? What are the criteria or parameters to decide on that?
Well, there are the recommendations of the ELSO organization and also of the World Health Organization, and basically they suggest to escalate to ECMO using the same criteria that were used in the EOLIA trial, meaning a PF ratio below 50 for at least 1 hour, or a PF ratio below 80 for at least 6 hours, or a refractory, let's say, respiratory acidosis, despite optimal optimization of the conventional ventilation. So these are the usual criteria adopted for ECMO. I have to say that if we adopted this criteria in our patients, we should have put on ECMO at least half of the patients, which is clearly impossible. So you always have to balance the resources you need to implement ECMO treatment in a patient with the number of patients who would need ECMO. So in real life, what was done was to restrict ECMO to younger and more severe patients. But the guidelines suggest those parameters that I told you a couple of minutes ago. Microphone.
Thank you very much, Prof. Grazelli. Again, another question for you. What practically measure do you suggest to initiate ventilation in the COVID patient immediate after intubation?
I would start with usually immediately after intubation, patients are sedated and paralyzed. So I would go with controlled ventilation. Pressure volume control is more or less the same, provided you know what you are doing and you set properly the alarms on the ventilator. So what I do is volume control ventilation, targeting a tidal volume between around 6 ml per kilo of ideal body weight. If the patient has a good compliance with the respiratory system, you can also increase the tidal volume up to 7-8 ml per kilo, provided that the driving pressure remains below 14 centimeters of water. And to set the PEEP, what we do is a PEEP trial, and we try to, let's say, tailor mechanical ventilation to the characteristics of a patient. So we try to understand which level of PEEP is associated with the best increase in compliance and the lowest hemodynamic impairment of the patient. If not, if a center is not really experienced, I would say that even if it's not perfect, the PEEP FiO2 tables, especially the low PEEP FiO2 table of the NIH, I mean, for clarity, that was the one that was described and adopted in the ARMA trial are okay. I mean, probably not perfect, but you don't do big mistakes.
Thank you. So the next question, does the use of N2O play any role in ventilation of the COVID-19 patients?
The use of what, sorry?
N2O.
NO, no, not N2.
Yeah.
NO, nitric oxide. Well, you know, since as Professor Omar showed, since VQ mismatch and loss of hypoxic vasoconstriction are probably two important determinants of hypoxemia in these patients. It's been the INO has been used and is been using a lot, is used a lot in these patients, and there are studies showing that you can use it at very high dosage, like up over 20 to 30 ppm. Again, we don't know, like in ARDS, some patients respond in terms of oxygenation. We still don't know if this translates it into an outcome, an advantage in outcome. But you know, sometimes those patients are so hypoxemic, and that INO can help you at least to see a better saturation. Then it may be only cosmetic, you know, maybe not really have an impact on outcome, but there are, as far as I know, there are no studies on that in COVID patients.
Thank you very much. So the next question, what is the general COVID ICU mortality rate?
This is a very important question. It depends on the population of patients you admit to the ICU. For example, as I told you, in Lombardy, we were able to admit only intubated patients. And clearly, patients undergoing invasive mechanical ventilation have a much higher mortality. Also, there are important differences also within the same region and the same country, according to the experience of the unit. So in the UK, for example, there are units that reported mortality around 25% and others reporting mortality up to 80%. So a difference in mortality of a factor of 4. From my experience, I would say that in our unit, mortality is 26–27%. Again, they are all intubated patients. In Lombardy, mortality is 39%. In Germany, it's just been published in the Lancet, mortality in intubated patients was 51%. And in the UK, I think that in the ICNARC study, mortality in intubated patients is above 45%. In France, 38%. I mean, you know, in that range.
Perfect, thank you. Kindly talk about bi-level as a mode of invasive mechanical ventilation.
Well, bi-level, which is called, for example, BiPAP in Dräger ventilators, for example. It's a mode that is exactly equal to pressure control if the patient is paralyzed. If the patient is not paralyzed, it's a sort of, okay, I'm going to say pressure assist control more synchronized with the activity of the patient. It's in some way different from APRV because the inspiratory and expiratory valves are closed during BiPAP compared to APRV, which is more a CPAP at two different PEEP levels. I don't know. It's a sort of again, it's a sort of pressure control mode of ventilation, more synchronized with the respiratory activity of the patient. So it's something that maybe you can use when you switch from controlled ventilation in a paralyzed patient to a pressure support or assisted mode of ventilation. It's like a hybrid mode. It's a reasonable mode, not really for COVID, like for any patient that is switched from controlled to pressure support ventilation.
Yeah,
okay, thank you.
Often APRV has been quite popularized, especially locally. I'm sure elsewhere in the world too now with COVID, and we've with COVID pneumonia at least. So obviously we found that, you know, often in the patient, you know, when they're not paralyzed and when we're struggling in terms of both the oxygenation and ventilation, and you need a higher mean airway pressure and you want to limit driving pressure, then provided they're allowed to breathe, well, they are not paralyzed, they tend to actually have much lower dynamic strain, because they can breathe at the top of the breath and low at the bottom of the breath, and they can maintain a high mean airway pressure. So really useful for a select group of patients, certainly, especially when they're not paralyzed, specifically when they're not paralyzed. It may be a handy tool.
Thank you, Prof. Omar. Perhaps, Prof. Omar, on that topic, since you went over to APRV mode, there is a question on APRV. So have you used APRV mode, and if so, what was the outcome?
Sorry, sorry, what is the question?
Have you used APRV mode? If so, How was the outcome?
Okay. Yeah. So I don't want to say. Yeah, the way I like to say is that certainly APRV is one of the modes that we consider using. And again, not everybody will get APRV or receive APRV as a mode, or some people, some patients might receive it. For example, initially when we've intubated the patient and we're struggling, or if we decide to paralyze the patient, then obviously they won't be on APRV. Often later on, when we're struggling with both oxygenation and ventilation, that's the group I find it to be most useful, because you're able to maintain a high mean airway pressure without having a very high dynamic strain. So you don't have to. Often when you need a high respiratory rate with a high driving pressure, that becomes a problem in terms of the mechanical power that we're using to, and that may damage the lungs. So what we do is we have a high mean airway pressure. APRV allows us to do that, and then we limit the number of release events, and about 50 to 70% of the minute ventilation actually comes from the triggers, the spontaneous triggers at the top of the breath. So if you set it correctly and you make sure you don't allow pressures to increase above your set points of 30, you can actually find that you can ventilate the patient reasonably well. They're quite comfortable. You don't have to paralyze them, and you're able to maintain a high mean airway pressure. But having said that, not every patient actually has both high ventilatory and oxygenation requirements. So you will decide when to use them. We've used them across the board, so I can't tell you, oh, it's associated with the best outcomes or associated with the worst outcomes. I don't have that data, and I wouldn't want to just guess off the last patient that I had. But certainly, I find it's a useful tool, and amongst the other tools that we have.
Thank you very much for the very comprehensive answer. So there's a question: what are the contraindications to the use of ECMO in the COVID-19 patients?
The same contraindications that you have in other ARDS patients, meaning active bleeding, and of course severe comorbidities, advanced age. So the same contraindications that we have in other patients. It's a little bit more tricky to manage anticoagulation due to the tendency of coagulation activation in these patients. But again, it's not a contraindication. We've been using ECMO in pregnant patients, even at around the 30th week of gestation. We've put prone pregnant patients in ECMO, on ECMO, without problems. So contraindications are the usual contraindications of ECMO, no one specifically related to COVID-19, I would say.
Thank you, Prof. Grzelli.
Maybe I could ask.
Yes, sure.
Could I ask a question? Yeah. Prof. Grzelli, just, we just starting our ECMO program, so we've received our consumables and so on, and there's a big decision whether we should actually use it in the COVID ICU or not, and if we're going to use it, the indications, obviously, in terms of timing, would we be using the standard EOLIA criteria, less than 80 for 6 hours despite all the interventions, or less than 60 PF ratio for 3 hours? Are we as aggressive as that, or do we give them a longer chance on ventilation with lower targets before you actually put them onto ECMO? What's your experience?
Again, we were so overwhelmed by the number of patients that we had to restrict the use of ECMO in very selected cases, and we used them in patients who were really with refractory hypoxemia and or hypercapnia. So it's been a real challenge. If we applied again the EOLIA criteria to our population, we would have we should have put on ECMO like at least half of the patients, which is basically impossible. It's very I think that one very important parameter to take into account is the timing of the ECMO connections and the duration of mechanical ventilation before ECMO. It's been demonstrated in ARDS, and I think it's true in COVID-19 patients that if you connect them on ECMO after 7-10 days of invasive ventilation, the outcome is worse, especially if you are not protective during these 7-10 days. Then clearly for very young people who maybe suddenly deteriorate or again very selected patients you can try. What we are observing is that mortality in ECMO patients, if you use ECMO as the really a rescue last resource, is a little bit higher than our usual mortality in H1N1 patients. For example, in my center, the mortality of ECMO patients is around 30%. For COVID-19, the average mortality of the center is like 26%, but for ECMO patients, it approaches 50%. But we really put on ECMO, I would say, desperate cases. It's so very, very, very severe cases that could not in any way be managed with conventional ventilation, but mostly due to resource constraints.
Okay. And do you have a time point? For example, if somebody is beyond 3 or 4 days, and you wouldn't consider ECMO or 7 days, or do you have any cutoff that you can, some practical advice to somebody starting on?
I think 7 to maximum 10 days. Not really, not longer. We've connected patients ventilated for longer, but little satisfaction.
Okay. No, thank you for that.
Perfect. Thank you very much. So the next question is, how do you manage asymptomatic pneumopericardium?
Pneumopericardium?
Yeah.
Meaning pneumomediastinum, I guess.
Yes. Yes.
It's a very frequent finding in patients who have been assisted with non-invasive ventilation and on some form of non-invasive support for prolonged period of time. It's related to large inspiratory efforts, and we manage trying to reduce the mean airway pressure, meaning to reduce the PEEP level applied and the positive airway pressure. We still use prone positioning, and we still try to use some PEEP. Clearly, we have to find the balance between you have the level of hypoxemia you accept and the need to expand the lung. For some patients, this is a clear evidence of barotrauma. For some patients, this is an indication to the extracorporeal support. If you need to reduce a lot the ventilation of the natural lung, it's a common but very challenging finding.
Perfect. Thank you. So how do you monitor progression of it? And I would take it that is referring to COVID-19. And how often do you perform imaging in these patients?
I don't know. Prof. Omar, you want to answer? It's
Yeah, no, I agree with you. I don't think it's it's a one size fits all. I think you'll monitor your patient's progress, and I think it'll be individualized. I don't think there's any set formula that you're going to be using. I think you're going to look at clinical progression and decide whether there's a new event that needs to be sought after. That's certainly how we would do it. So I wouldn't be having some sort of strict protocol in terms of imaging.
Perfect. So I would like to ask, what is the general accepted mortality rate for COVID ICU?
Again, I answered before. Accepted that there is no accepted mortality. I think that there are mortality reported in the range from 30 to 80%. The largest case series are between, let's say, 35, 36 to 50, 51, 60%, something like that. Then there are extremes, but severe ARDS has a mortality around 40%. So basically in that range.
Yes. And I think I put some data from the scoping review, from your scoping review, from that UK study. And recently we've had a little webinar with 4 countries: the UK, Spain, Brazil, and South Africa, our unit. And the mortality was pretty much between 40 and 50%. So that's really, at least for ventilated patients. And so that's pretty much what you can expect, but obviously there are going to be variations depending on the individuals that you get into the ICU.
Absolutely. So the next question, what is the end point for prone positioning if it is not improving the gas exchange?
For me, every patient with ARDS and the PF ratio below 150 should be prone until he deteriorates during prone positioning. The improvement in oxygenation is not related to the effect on outcome. So I would follow the criteria of the PROSEVA trial by Claude Guérin, published in New England Journal of Medicine. So you should stop proning the patients when they get worse during prone positioning. Even if PF ratio does not improve, this doesn't mean that prone positioning is not useful. Clearly, if you have to prone 10 patients every night, then you also have to reason according to the resources you have. But let's say that in an ideal world, for me, prone positioning should be standard of care in all ARDS patients with PF ratio below 150.
Right. So there are still a number of questions. So I will allow for one more question, I think, and then we will end off the session. Your questions will be answered. We will send your questions to the speakers, and they will compile an answer for your questions, and these answers will then be sent out to all the attendees. So to Prof. Grazelli, in your setting, have you seen an increase in metabolic decompensation, so DKA, especially newly diagnosed diabetics? A lot of the Chinese studies have published this. If so, what do you think this association is due to?
I don't know. We haven't, I have to say that we haven't seen an increase in the diagnosis of diabetes. It's also very difficult to, in the ICU, many patients have increased glucose levels. It's very difficult to establish a diagnosis of diabetes in the ICU, especially now that all patients are treated with steroids. So I can say that if the question is related to type 1 diabetes, I mean diabetic ketoacidosis, I've read some reports of increased ketones, but I haven't got that experience. The only thing I know is that patients with diabetes, especially the compensated diabetes, may have a worse outcome. At least in our studies, but not only in our study, but in many studies, diabetes is one of the few comorbidities which is associated with, also at the multivariable analysis, with an increased risk of death, while, for example, hypertension is not. I don't know the mechanism. I cannot tell you anything more than that.
Perfect. Thank you so much. So I think we do need to end off the session. And as said, your questions will be answered. We will send these questions to the speakers and allow them to provide us with an answer. And these answers will then be sent out. So I'd just like to once again thank both our guest speakers, Prof. Gazelli and Prof. Omar, for taking time out of their evening as well as out of their schedules to prepare these presentations and for enlightening us with their extensive knowledge. Both presentations highlighted important data and revealed some very interesting facts. So thank you once again for your participation in our webinar. I would also like to thank all our attendees for attending and for your attention this evening. Thank you for all the questions. And as mentioned, we will get those answers to you. Just to reconfirm, for those who did join a little bit late into the webinar is recorded and the recording will be made available at soonest convenience. So with that, I would like to end off our webinar for this evening and wish everybody a wonderful remainder of the evening, what is left, obviously depending on where you are in the world. And thank you for joining, and thank you once again to our speakers. Well done, was a fantastic presentation. So thank you everybody, and goodbye.
Thank you.
Thank you.
Bye-bye. Bye-bye.
Bye-bye.
Thank you.
Bye.